computer. So we will start now. Again, the infection has a very much increased in worldwide. So we want to know about what is the definition, what is the classification, what are the tools that are important in diagnosis, and how to manage each patient on the basis of a local and systemic antibiotic and the algorithm that we want to use. Actually, this is the part one, as we said. So as an introduction, many advances in the prevention of the surgery, yet there are many increasing the post-operative infection. There are still 2.2 after any primary surgery, after primary replacement of the joint, and revision up to 7.8. And you can see these numbers in many suggestive literature recently have doubled from the last 10 years. So one must consider as a common cause of failure in the total joint replacement. As you can see this graph, the infection has more rate than other complications like instability, periprosthetic fracture, aseptic loosening, and wear. So once you have got any of these other things, other complication, you must rule out infection first. It is not simple that you can take, when you take a patient that requires a lot of resources, a lot of teamwork you can do with. And the best thing is that when you have a patient with a very successful hip replacement surgery, as it is one of the most common successful operation, a more impact for the quality of life that increases elderly population as suggested in this JBJS 2004. So these patients may have such emerging and devastating complication, like what you see in these pictures for the total hip and total knee. So it is a dilemma whether it is an infection or not. It depends on the clinical and laboratory and imaging studies. Although it is not simple when you take it, that requires, as we said, a lot of resources and a lot of teamwork. So you have the best teamwork with you is the plastic surgeon, the radiologist, and even the microbiologist. You must sit with him to for the teamwork for eradication of infection, as well as a vascular surgeon when you have such a devastating problem. So regarding definitions, we have to know that, regarding definitions, the PGI is not only periprosthetic interface. It is not from the bone and the prosthesis. It is the bone, the soft tissue as well. So when you have an accurate diagnosis, it's true for the clinical challenge. Every patient without local signs of redness, every patient who does not have a pus and post-operative joint pain, you must consider it as an infection until you prove it otherwise. So a multidisciplinary team you have to take down with you before you take any diagnosis and any definitions. Many classification, we will see how we classify the periprosthetic infection and the treatment and adapted to case. And actually, this one will be in the part 2. So regarding the microbiologist, you must sit with your lab colleagues and discuss this one. The discussion about the bacteriostatic and bactericidal drugs that everyone, including me, I don't know much about it. But however, you can see that the vancomycin and levofloxacin are most commonly used in our orthopedic field. However, you must sit down after if you have got an isolation of the microorganism after you do the investigation. And that's why you have a multidisciplinary team in your work. When we have got an infection, we have to be in 4 aims. First of all, the patient's life. Second is the limb-saving procedures. Function of the joint must be restored, and eradication of infection. Eradication of infection per se is very difficult, as there are many classification systems, as we said before, in the text, in the literatures, when they are generally classified the infection into three types, as we see: an acute, post-operative, chronic, and the hematological or hematogenous infection. So the ICD group have these people in all around the world that have a meta-analysis for the management since 2007. Until now, they were keep changing the criteria of classification and the diagnosis of the joint infection as well. However, you can see that the major criteria to identify and find out the periprosthetic infection includes one of two major criteria and one of the major criteria and three of five minor criteria. You can see now the major criteria: if you have a patient with a sinus discharge or a microorganism isolation or any of the one of four criteria in this situation, this is an infection, but still there is a suggestive not proven. So anyhow, we will see how to deal with in each. Any of these classification, the classification system, as we said, it's time dependent, before 2 months up to 1 year and any time. And the perioperative, whether it is early, post-operative, or delayed, it depends on the signs and the causative microorganism. However, the late type here, you can see the hematogenous infection, which is mostly occurred by Staph aureus as an acute or subacute. So any of these classification you can use and apply the major and minor criteria. However, don't forget that any of these classification ignore one important thing, which is called the biofilm. The biofilm that is produced from the bacteria and multiplication and adhere on the surface of the implant within minutes and hours, and embedded matrix in 70%. With a slow replication, sorry. So we have a clinical notes. Diagnosis of periprosthetic infection begins with medical history, clinical examination, and obtain and appropriate radiographs. First of all, look at the time of onset, the location and character of pain. Should be noted, as well as any history of chills, fever, and wound drainage. The hip joint must be fully examined for a drainage, erythema, and or swelling. The knee joint and range of motion as well. The principle in the history: any painful joint that post-operative, in the absence criteria above, it is infection until proved otherwise. If you have a failed implant within 2 years of surgery, this is an infection until proved otherwise. Any late sinus drainage is a major criteria for infection. And remember, please, there is no such thing from the skin incision into the prosthesis you made. No, it is not. When the infection occurred inside the joint, inside the prosthesis, it emerged out of the prosthesis into the skin, not the vice versa. And most patients in our Middle East came with a later after bony destruction, so that will make the problem more difficult, especially an action must be made immediately. So, as a result here, we will start as a preoperative and intraoperative investigation and tools that all of these combine together in order to reach the diagnosis. please do not depend on simple hematologic and simple imaging studies because they are altogether combined as the literature 2012 of Burns in the hip joint infection as proposed. When the laboratory markers are used, we see that the ESR and CRP is sensitive and it's almost always not specific. Because of that, many suggested other investigation. Remember that the serum interleukin is also a better sensitivity in most of the centers. However, many centers in the Middle East shows there is not significance also. The infection may be from not only its joint, but also from a UTI, upper respiratory tract infection, a dental caries that raises these markers. Remember, the serum complete count is not an indicator, so it is not used. Serum amylase, you have to find out the serum amylase, especially for an immune compromised patient with irradiation, diabetes, steroid use, or emaciation. So in laboratory test, ASR is a low specificity. The leukocytes are not discriminatory for the presence or absence of infection in the serum. The C-reactive protein is most relevant one. These are need to be repeated always, and these interleukin-6 tumor necrosis factor only costly without any benefit. Because of that, the 2010 JBJS suggested it is only suggestive of infection. Again, with the lab markers, be careful about the immunocompromised patient, please, as we said. And regarding the lab markers, the synovial fluid aspirate. Here, we have seen in the criteria, which is in the acute for more than 1,000 per microliter, more than 1,000 neutrophils, or even more recently in 2017, suggested 500 per microliter in acute infection have shown in most cases of infected joints. Another thing is that the alpha-deficient immunoassay, which is called the Synovia Sure, it is a natural product that is produced by the neutrophils as an antimicrobial peptide recently. And they have found it is a pathognomonic for the joint infection, while actually it is not, according to this literature in front of you in January 2019. They suggested that it is not specific for infection. Although in PGI it shows this one has raised in more than other disorders, like whether it is aseptic loosening, in inflammatory arthropathy, and also in some cases of osteoarthropathy. So this level is higher in infection even in the patient with an antibiotic. So it is suggestive as a sensitive but not a specific for infection. As you see, the synovial fluid culture, again, the analysis here about 40 patients in 2018, it is suggestive that it is more specific and sensitive. But here, it's sensitive but not specific. So in culture, as you will see later, it is more specific here. The culture tissue or a synovial biopsy, you can do the joint aspirate is a very good now, and the synovial biopsy by either arthroscopic or mini open. Remember, it is very useful in knee surgery better than the hip. And we take multiple sites of biopsy. Remember that there are a false positive contamination of sensitivity in these lab investigation about the biopsy. So combining the sensitivity of aspiration is about 40% false positive, while the synovium synovial biopsy about 80%, but if you do both, it will increase the rate of sensitivity of periprosthetic joint infection. Another thing is that what is called the sonification or sonication of the biofilm bacteria. They used to take down the implant and put it in this part with a special fluid and go with the ultrasound waves, so that in 2007 they suggested that it is detached from the biofilm, which is very hard, and then you can aspirate it. Remember, it is very difficult when you isolate a bacteria with a Staphylococcus epidermis because of a high false positive results will occur. You can see it is Staph aureus between the tissue biopsy and sonification fluid or sonication fluid, which has a better sensitivity, a quality, and mixed infection, which has faster, less expensive, and fluid for the additional investigation. The agar they used usually is a long term, usually more than 10 to 14 days. The intraoperative frozen section you can do after you primarily suggested to open the prosthesis and remove and you divide everything. You can take a frozen section. More than 5 polymorphonuclear in a high power is a suggestive of a high risk of infection. Remember that some of them came with no gram stain. So please do not ask for gram stain. Ask for the polymorphs in the frozen section or after you take a biopsy. 1/4 of the cases may be resulted in no bacteria, which is not exclusion of infection, especially when you see a soft tissue debris or loosening by the X-ray, or you have a preoperative lab investigation that is suggestive of infection. Regarding the X-ray imaging, there's another point regarding the microbiology. When there is a gram-positive agents, gram-negative in the Middle East occurs more. So as you see here, 1/4 of the patient may result no bacteria, or sometimes in the frozen section, they does not suggest a gram-negative because the gram stain is not always applicable in the frozen section. So because of that, a biofilm is really hard, especially when a gram-negative infection occur. And this will develop a very quick within 1 month, so you cannot eradicate infection without removing the implant. That's what I want to say, because if you have an infected implant, you have to remove it immediately. Otherwise, the biofilm will be developed as fast as it can. The imaging X-ray, although it is not sensitive, but you have to examine the loosening around the prosthesis, scalloping of endosteum, and perosteal reaction of occur. And I urge, if you see these findings, ask immediately about a previous X-ray film to find the progressive aggressive change in the pattern. If the X-ray within 1 month occurred these criteria, this is an infection until proved otherwise. Sometimes, as you see here, the X-ray, I'm sorry, it is not very clarified, but here you can see a loosening in the stem with a defect in the stem, and this is a cantilever type. And this is the X-ray immediately post-op, and this is within 3 or 2 months. So this is an infected stem of the femur. Another thing is that the CT contrast. You can see that the CT contrast is very useful if any collection of a fluid or abscess around the prosthesis. Remember that the bone scan, it is not a definitive for infection, as the uptake, it will increase at any reaction of inflammation, of an osteoarthritis, or even in post-operative joint replacement. So the report comes infection cannot be ruled out Although indium white BC labeled is a very sensitive, yet it is a high false positive result. So I suggest if you have a suspicion with the bone scan, you have to look back for the principles of the lab investigation, laboratory markers, X-ray, and the MRI. The MRI actually is not a mere MRI as we routinely require. This MRI is called Mars, and I can show you that the with this one. I think we can write now. Yeah, you can see the implant of the hip is here, the femur is here, without artifact imaging around the hip joint. Okay, so it is very, very important to send for it. And also, sorry, yeah, metal artifact reduction sequence. Yes, MARS is a stand for metal artifact reduction sequence. Actually, I was saying that, but I want drawing these from where I can move it. Okay, and you can see now in the cross-sectional view how the fluid collection around the cup of the acetabulum, and this is the acetabulum infection around the cup of acetabulum, right? In the previous X-ray, you can see a high signal intensity at the superior pole of the acetabulum. And here, it is very clear in T1 Mars image. So if you have now any question at the end of the part, I'm thankful to answer. Let's go to the chat and see if you have any questions about this subject. Well, actually, Dr. Saran, thank you for this question. Do every bacteria able to form biofilm? There are many bacterial causes, mostly the aggressive one, which is the gram-positive, and the Staph aureus, MRSA, yes, very much causing a biofilm. Actually, I don't know if the other non-virulent microorganism can cause a biofilm. The question here, another question is that how is amylase could be used to assess immunity? The immunity actually, it's not only the immunity per se, it's only for the, as you see, it is for the compromise, if it is raised or not. These patients have raised in the serum amylase that they cannot cooperate with the fluid. So I don't think it is a referring part of the immunity. Yes, apart from the fluid collection, any other MRI signs for periprosthetic joint infection? Well, actually, if you can see, first of all, you can see this, you send the X-ray at first. The MRI will suggest that there is a loosening around the acetabulum, and if there is any fracture or any dislocation or a change in the position. But MRI, actually, the fluid collection is more important, or any soft tissue change in the signal intensity around the cup or around the stem or the implant as well, because many of them have been suggested there is a bone implant interface, there is a gap, and tissue reaction may occur. Is there any differences in definition of periprosthetic joint infection? I don't know, because this is the definition of infection still yet to be recognized well, both of them, FRCS and AAOS. Um, they have been suggested for many times about the cause of infection and the what are the risk factor of infection, and whether it can be dealt with the criteria. So infection is not just infection of the prosthesis, as we said, and accurate and efficient diagnosis is still the true clinical challenge, but recently not universally adopted as a gold standard. There is no gold standard definition for the PGI actually. So it is only according to the international, I think, yes, ICM, International Consensus Meeting on the PGI, they have defined the PGI as the major criteria and minor criteria as well. Dr. Lay, no clear-cut investigation for the diagnosis of infection, or it is a matter of a high suspicion. As you know, the treatment depends on the time of diagnosis and will change with the time. So how can we decide the best treatment? Depends on the tool of diagnosis. Well, first of all, you have to raise the suspicion in any part of these criteria. And then the timing is very important, as you said. That I think that you have to take down everything immediately. Do not delay it. Do not make the patient take antibiotic for more than 2 weeks in order to reduce the serous fluid discharge, or decrease the erythema, or to reduce the pain. You have to put down these things first. You have to make the treatment plan as much urgent as possible. This is first. The second thing, Dr. Lay, is that you have to make more than one plan in regards of the infection, because you may change this plan immediately into a plan B. For example, you will see in the next or the part two in the few days later regarding the treatment of infection. You can change from a single stage to a two-stage operation. You can change from the two-stage into the first only, or you can do whatever you can put fixed for the function of the implant. So I don't think the time, yes, it is very important. Investigation, as you see, and how to reach the diagnosis is a matter of collection of all these tools. But there are many tools that are not useful. You don't spend money for the patient as the interleukins or as the white BC labeled Indium. Dr. Saran, routine culture for TB will be negative, yes. How approach should be suspect TB in a case of infection? TB case, when there is a suspicion, this is a very, very important question that has been raised in the AO Recon. I remember that in the AO Recon surgery meeting, they suggested that the suspect with a TB is merely the basic investigation of anti-TB, or sorry, of the acid-fast bacilli. This is first. The second thing is that when you have a positive or a suspected chest x-ray for a TB patient, immediately you take your patient into the operating room and you open with a culture and sensitivity. All right, with yes, culture and sensitivity or a biopsy. Doctor suggested another question. The time of surgery, is it important or not? Yes, it is important, because the timing of surgery, once you have got or raised the suspicion of infection, you have to be in less than 3 weeks. Otherwise, the biofilm may be formed and you can do more aggressive surgery by taking down all your implants and taking off your implants from the bone, and you may have a gap. Another question, duration of a procedure affects getting infection. Well, The duration, yes. When you have a primary, for example, primary total hip, and you spend more time. This is very important criteria when you are dealing with, as we see first in teamwork. The teamwork suggested that the AOS suggested that the teamwork, sorry, must be with an expert surgeon. Even if you are doing a primary totally or you are primary total hip, primary joint arthroplasty, this is very important when you have got this part and you are with an expert surgeon. It will decrease the infection rates. Yes, I think this is the meaning of your question in the primary. But I will answer the other part, Dr. Ismail. If you have, for example, an infected joint, a periprosthetic infection, is the duration of the procedure will affect? No, I think the duration is not. Because many literature suggested that a meticulous technique for the primary or first stage operation after you got an infection, meticulous technique of well-divided tissue, bony and soft tissue, okay? This is very crucial in the first stage. If you are doing this two-stage operation, you see what I'm saying. I think I got your point. If I'm not, please rewrite the question again. Dr. Musab, are synovial fluid inflammatory marker more specific than serum markers? Any data of synovial fluid marker value to confirm PGI? Dr. Musab, we said that previously in the lecture. There is no confirmation. It is raised the suspicion only. This is first. And the second thing is that, yes, the synovial fluid inflammatory marker by aspirate and tissue biopsy is more sensitive and much specific than the serum inflammatory markers. Yet no specificity for a specific infection per se. Dr. Sarkan, thanks for your lecture there, ANR. I'm sorry, what does ANR stand for? I'm sorry. Thank you very much about your compliment. Dr. Ismail, how long after joint replacement is a time for getting infection? I mean, risky period. Well, this thing is very controversial and it is dilemma. They are raised the suspicion of any joint infection from 2 weeks actually until everyday life, because one of the AAOS group I attended, and they have suggested that once you got the implant inside the endosteum of the bone, there will be a risk of infection. But one of them asked about if you have a cementless prosthesis. There is no cement. There is only bone and the material of the implant. How come there will be there's infection? You know that a hematogenous, a long term, once it got there from any route of infection, it will go through the synovium and then it will cause infection actually. I think that the question is very sophisticated and requires multi-analysis studies, because I think, Dr. Ismail, the AOS is till now, they have been suggested for the timing and the risky period. Yes, they have suggested that, but still no clear cut about this. Okay. Everyone, Dr. Everyone, how are you? Dear Dr. Sinan, may I got agree with you to take all implants out in acute infectious always? Okay. Actually, first, I'm very thankful for this question because it will open up the part two. Actually, I'm not not discussing the part two after infection, but however, I will answer your question. In acute infection, there are dependent factors, okay? You have to be sure about the patient, first of all, the history of the patient, the general condition, whether he is emaciated, elderly, and the third, sorry, is that which microorganism is affecting. For example, let's take a question that is raised in the AO recon. When you have a well-fixed implant and you have everything fine about the ESR active protein, okay? And still there is a joint pain after 4 months of total knee arthroplasty. And you do aspiration, and you suggested, and you go for the microbiologist after that, there is a MRSA positive. What will you do? If you are going to go for a DARE, for debridement and implant retaining, or are you going to go for immune suppression drugs only, suppressive drugs only as an antibiotic long term, or are you going to go for a revision 1-stage or 2-stage prosthesis? This is very crucial. When you have everything looks fine and the X-ray looks good, it's only 4 months. It is not so chronic, all right? It's below 1 year. And the second thing is that you have normal or under a standard C-reactive protein titer. I depend on myself, I depend on the C-reactive protein. In the acute phase below 1 year must be not more than 100. And he's not elderly, and as we said, he's now elderly male and emaciated. I think a DARE with replacement of the polyethylene, which is very beneficial. This has been suggested case in the AO recon. So it is not always to take down all implants. You have to be careful about the patient condition first. And second thing is that when you go for a revision surgery, you must go out first of all, remember that, to take the information of the patient and the implants that have been implanted before. Okay, Dr. Sarkan, is there any role of infusion antibiotic to the wound to decrease chance of infection? This is a very interesting question. Actually, in the AAOS, I surf the net and the AAOS, and there are suggested literatures between whether to eradicate the infection during the first stage, or are you going to single stage operation. You have to take down all the implants, take it away, and then you are irrigating. Is it only copious fluid? Is it with antibiotics? Or is it with a jet lavage? Actually, all the same. So at the end of the this run, they suggested that you don't need to put a high costly antibiotic. They are costing the antibiotic so much, especially the vancomycin. So we have to infuse with a copious amount of about 6 to 9 liters of normal saline without lavage, because there is a still dilemma. But however, in the end of the run, yes, it's not always infuse the antibiotic, even if you are going to do a primary, all right, without an infection, sorry. So, Dr. iPhone ASO, if you delay 15 minutes during the primary arthroplasty, increase risk of infection about 0.9%. Yes, many literature suggested that the primary arthroplasty raising the risk. Yes, thank you very much about this information. And one of the literature suggested that a delayed the delayed surgery, not only in 15 minutes, but also if you are delaying the recovery too, not only the surgery. Thank you, doctor, about your information. Dr. Lai, if you have a draining sinus, is it mean go for surgery, or there are another steps to do? Look, sir, sinus means that when you have got an infection, whether it is superficial or deep, as you want to say, because this is a question we ask about, and we are inquiring about, however, how is the infection goes from the implant into the surface of the skin, not the vice versa. Because the superficial infection, it means that it's only the dermis of the skin and the threads that are causing the infection, all right? Many have suggested that the sinuses, you have to take down it. But however, another step is that the ultrasound guided, many have them forget about. But actually I used to do it in my clinic, and I send for ultrasound guided sinus or sinogram in order to find out whether the sinus is only superficial or deep. And regarding to answer your question, actually, I found 4 of 6 patients after I doing the ultrasound guided or sinogram. It is not on. Not only the dermis of the skin. It's not only superficial. No, my dear. It was from the deep. Yeah, from the joints. So I make them a plan for a 2-stage operation. Dr. Anas Sadun, thank you, doctor. My question is that what time interval divide the infection to acute and chronic? Well, you can see the this one. I will show you here. The criteria of acute and the chronic, it depends on the time and the route of infection. It is not only the time. Actually, the early post-operative infection, we said about 8 weeks only. That's what we said in the lecture. According to Zimmerli in 2004, he suggested that, or they suggested that, and in 2006, they have a meta-analysis about not only the time, it is about the route of infection. So it is in the perioperative or a hematogenous. Hematogenous infection, it is almost always late. It is more than it occurs anytime, but later than 2 months. More than 2 months, again, in the perioperative period, within 1 or 2 years, it is a delayed or low-grade infection, which is called a chronic infection. Okay, so you have the acute within 2 months, you have the chronic within 1 to 2 years, and you have the hematogenous occur at any time later than 2 months, which is called acute or chronic, as we see in the literatures. Still, there are in the ICM, still there is no definitive classification for it. And remember, please remember this part, because the classification didn't form that the biofilm, because the biofilm have affected the classification and definition of periprosthetic joint infection. Okay. iPhone, thank you for your presentation, and thank you very much for a compliment. Thank you very much. Okay. Are there any questions that we can share with? And I hope our mentors who have come here in this webinar, I'm very honorable to be with you. I'm very honorable to learn from you. I'm very glad to be here. I wish that everyone can share other ideas. Maybe I forgot many ideas, sorry. Sorry. Well, I'm very thankful. Oh yeah, there are questions. Dr. Ramond, do you recommend to put drain after surgery? Have any role to decrease or increase infection? Well, if you are asking me, I will share my idea. First of all, in total hyperarthroplasty, I would never do any drain. I would never put any drain, because first, a meticulous drain, a meticulous and copious amount of a fluid, irrigation, without lavage, I don't use it. And the second thing is that a meticulous and proper tissue approximation, or suturing. Suturing in layers, however, more than 6, 8, it is okay for tissue generation. And especially in the joint, both the hip and knee, I usually do what the literature suggested of intra-articular tranexamic acid, 500 milligram, with antibiotic like a vancomycin injection inside the muscle. For the knee, yes, but it is not for decreasing or increasing infection. It's only for controlling the blood transfusion, because many have suggested that when putting one drain with tamponade of about 1 hour, you can decrease the risk of blood transfusion. However, many suggested not, because it is still there is a dilemma between both, which a controversy about using a tourniquet or not. Yeah, it may have to increase the risk of infection in few, but in level 4 and level 3 literatures, I see that they are using the tonic, especially in the total head. But however, I don't use drain for the total head at all. Okay. Thank you, sir. Thank you for presentation. Thank you very much of compliment. Yes, it will be on the not only the Telegram groups, it will be on the YouTube. I hope so. I hope you are enjoying this part, and we will wait for few days later, and I will announce about the part 2 about the treatment of infection. And I hope you are enjoying very much and more sharing of your ideas. Thank you very much, and goodbye.